it's top of the hour, so we're going to get going. First, I want to welcome you all to our final session in this 5-part series, Organizational Initiatives to Prevent Patient Harm from Opioids. Today's session is Opioid Prescribing Best Practices, and your presenters are Dr. Bobby Redwood and Dr. Rachel Dibble. Next slide, please. Bobby Redwood is an emergency medicine and physician and graduate of the Rush University School of Medicine in Chicago. He finished his residency at the University of Wisconsin Emergency Medicine and Preventative Medicine. Dr. Redwood's portfolio includes opioid stewardship, opioid use disorder, and physician engagement and quality improvement. Dr. Redwood also serves as the physician lead for the Midwest Alternatives to Opioids program, the Wisconsin Dental Pain Protocol, and a tri-state coalition to reduce opioid overdoses in long-term care settings. He serves as a state chapter president and national quality and patient safety counselor for the American College of Emergency Physicians. Rachel Dibble holds a master and a doctorate degree in nursing. She specializes in adult primary care and geriatrics with 20 years of experience. Her professional background includes quality assurance, clinical operations, hospice, and palliative care for many healthcare settings, including long-term care and short-term care, assisted living, hospitals, communities, and clinics. She works for Superior Health Alliance as a subject matter expert and a quality advisor for the medication safety and chronic disease management teams. Her experience in pain management within these settings has given her a breadth of knowledge regarding the patient population with substance use disorder or opioid use disorder requiring treatment with medications for opioid use disorder, or MOUD. Next slide. The objectives of our series have been to identify organizational opportunities to reduce harm caused by opioids, describe alternatives to opioids for treating pain, learn best practices in opioid prescribing and stewardship, describe stigmatizing language and its impact on patients seeking treatment for opioid use disorder, and identify practices necessary to ensure safe transitions for patients taking medications for opioid use disorder. Next slide. The objectives for this session are to explain the core principles of prescribing opioids safely and minimizing your patient's risk for opioid use disorder, explain why shared decision-making in pain control increases patient engagement in the care plan, and understand how to create a safe prescribing practice within the healthcare setting. Now I'll turn it over to Dr. Redwood. Dr. Redwood, next slide.
Thank you, Candy, for that warm introduction. And thanks to everyone for attending our final session. This is kind of putting a bow on everything. The idea that opioids are never going to be used is unrealistic. These medications have really revolutionized the way we practice medicine. We are not doing Civil War surgeries anymore where you bite on a stick, right? It's allowed for so much high quality, good patient care with caution, right? And the preceding modules, a lot of that has been about the cautiousness that we need to take around prescribing opioids, alternatives to opioids, other ways to manage pain. And that is not lost on this session either, but this is revisiting when you are going to prescribe an opioid, how to do it safely and responsibly. And to be honest, kind of a state of the art. We're putting a bow on it because it's been, 25 plus years that we've had guidelines on how to prescribe opioids safely. And our understanding and knowledge has really changed. And you probably have conflicting guidelines. You probably have guidelines from your specialty organization or your hospital, guidelines from your state or your state hospital association. And so we're just kind of summarizing all that, bringing it together and giving a state-of-the-art best practices for prescribing opioids when they are appropriate. You saw the slide in alternatives to opioids module, but the big deal with opioids is that continued use leads to rapid dependence. The idea is when you're on an opioid for a long time, there's a very good chance, unfortunately, that you're still going to be on that opioid 1 year from now, 3 years from now, a lifetime from now, right? And if you look at the x-axis here, this is the days of supply of a first opioid prescription. And the y-axis is the probability of continuing use after 1 year, the bold line, or 3 years, the dashed line. So again, thinking back to 10 years ago when someone had their, shoulder or joint done and they got 100 tabs of oxycodone, that's a good 30 days worth of that medication. The chance that they would still be on that oxycodone 1 year later is around 35%. The chance that they're still on it 3 years later is around 20%. The original narrative that these medications did not cause rapid dependence or addiction was untrue. And we now have a much better understanding that we want to be prescribing opioids in a very short course when applicable. So if you look at that 5-day supply, if you're giving an opioid every 6 hours, that'd be about 20 tabs. And that would kind of minimize your risk. That would put you in the 6% or less zone for still being on an opioid 1 year later. In my current practice, that's how I've seen it evolve. When I first started training, we were prescribing 30 tabs for an acute injury of, choose your short-acting opioid pill, then 20 tablets, then 10. Now I'm down to 6 in my practice. I'm prescribing a day and a half of opioids and really educating my patients to use these medications sparingly. We talk about the 5 principles of prescribing opioids. The first principle is just that, is know the boundaries. And I like this little cartoon to the right. The idea here is that there's a lot of patients who are going to be coming into your practice in pain, and an opioid may be acceptable for some of those patients, but certainly not all of them. And so you do want to draw some boundaries around when to use these medications. And a lot of the resources that we use here are actually the Minnesota Hospital Association's opioid roadmap. It's an excellent new resource, and a big part of it is knowing those boundaries. So here's how I think of it. Opioids are reserved for acute pain. They are really not used for chronic pain. And my challenge for any prescriber would be, if you are prescribing an opioid for chronic pain, you should be able to clearly articulate why this patient is not at risk for opioid use disorder. Because we know that long-term use of opioids leads to opioid use disorder, rapid dependence. And there's very few exceptions to that. One of them might be end-of-life care. Maybe this patient has a really painful cancer. They're going to be in pain for the next 6 months as we allow natural death and they exit this world. And maybe that's an appropriate use of a long-term opioid, for example. But there's not a lot of exceptions to this rule. Opioids are a medication that we prescribe for acute pain. Another boundary would be offer alternatives to opioids first. We had a whole module on this, but all those little, blue balls outside the yellow circle there on the cartoon, those are patients who, we want to try modulating their pain with multimodal pain control, non-opioid, lower risk pain control. And only if they fail those modules, then do you want to consider a short-term opioid for a very specific reason. And alongside of that, opioids are prescribed as a last resort. They're not the go-to first option, but rather try this first, then this, and you're kind of walking down an algorithm with an opioid as a last resort if other pain control modalities have not worked yet. The other big concept here is, does the benefit threshold really meet the risk threshold? So we were using, 15, 20 years ago, we were using the pain scale, and a lot of places realistically are still using the pain scale. The problem with the pain scale is that pain is a very subjective experience. And that doesn't mean that your patient's not in a ton of pain if they come in with a flare-up of a chronic condition, like gout pain or like fibromyalgia pain or an irritable bowel syndrome attack. These are very painful conditions. However, we've really learned that certain types of pain respond well to opioids and certain types of pain do not respond well to opioids, especially because of that rebound phenomena with episodic pain, where patients can take an opioid, their neurotransmitter, their mu receptor gets flooded with neurotransmitters, the opioid wears off, and suddenly their pain bounces back more fierce. And so we think of acute, severe, self-limited pain as the type of pain that might be appropriate for an opioid. And in my practice, I'm an emergency physician, I'm really thinking about broken bones, post-operative pain, and cancer pain. This is pain that we think is going to go away. That surgical wound's going to heal, that broken bone is going to heal, that tumor is going to be resected, or that your tumor burden is going to be treated with chemotherapy or with radiation. This is pain that should go away in the near future, and we are bridging you through that painful episode. We do not use opioid pain control for chronic pain, and I call this the no-go zone. Episodic or chronic pain, that would be things like headache syndromes, gastroparesis, fibromyalgia, dental pain. I think we did our patients a lot. I think we caused a lot of opioid use disorder. I'm pointing three fingers at myself here. When every time someone came in with dental pain, instead of making sure they got definitive dental care to get that tooth pulled, we gave them an antibiotic and some Percocet. And then they never got their tooth pulled, and the infection came right back 10 days after the antibiotic wore off. And that patient is now getting a course of opioids from a different emergency department every month or so for the next year. That is not where we want to be in medicine. We are now causing more harm than help there. And so establishing those norms and just saying, you know what, this doesn't meet the threshold. I appreciate you're in pain, but this really isn't a broken bone. It's not postoperative pain. It's not cancer pain. Let's see what other alternative we can offer. We want to protect our patients. And the main way that I think we protect our patients, or my graphics a little out of sync there, that's okay. The first thing I really ask is if they're even interested in opioid pain control. A lot of patients, if you just prescribe an opioid, will take it. If you ask if they are interested, they will politely decline it. And so I think that's the first key step when you're kind of testing these waters of, is opioid pain control right for this patient? And then you want to screen your patient for opioid use disorder risk factors. The big one is, have you ever been addicted to morphine, fentanyl, oxycodone, Dilaudid? I sometimes have to say the drug names because if you say opioids, patients will say, no, I've never been addicted to an opioid. Oh, but yeah, I was addicted to fentanyl. But that simple question, you'll be surprised when patients say, oh, actually, yeah, I was in rehab a couple times for XYZ. And you could really apply that to any substance, amphetamine use disorder, benzodiazepine use disorder. If someone has a history of medication misuse, these are probably not the medications for your patient because the misuse of these medications is rampant and has pretty serious consequences. Of course, checking for medication interactions, the big one being benzodiazepines or other sedating medications, daily alcohol use as well. You know, I'll have patients come in, they say, how do you take your Percocet? I wash it down with a beer. No, that's misuse of your medication. And I always check for life interactions as well. Are you a driver? You know, is this going to mess with your CDL? Are you going to have mountains of paperwork? Is it really worth 6 tablets of this medication for the clerical burden I'm about to put you through? You know, what about taking care of young children? Do you have someone who's co-sleeping with you? Are you putting them in a playpen at night? You need people to be alert and apt for these life activities. This could really mess up their life. And then, of course, explaining the side effects. And if you've heard me speak before, it takes 5 seconds. These medications have a risk of overdose. You can get hooked on them, you can get constipated, and they can make you loopy, right? So opioid side effects are pretty easy to rattle off, but you have to say them to people. And a lot of times hearing that kind of pause button before the prescription goes out, it makes all the difference about whether or not these patients will accept the prescription. The third boundary is actually for you as the practitioner. And I know we have a lot of quality improvement professionals here as well, but this is something that we really want to hammer in at our med staff meetings, make sure people are on the same page, is we are now in the era where pharmacists and physicians and PAs and NPs are getting sued for inappropriately prescribing opioids. And so there is real liability here, professional liability. And it's also good for the patient, right? Check the PDMP for diversion. Many states, this even includes caregiver diversion, where you can see if a caregiver has opioid use disorder, because we all know that these medications go in the medicine cabinet. They may be going to your patient, they may be going to their caregiver, to the local high school, right? This is very serious. Check your institutional protocols about safe prescribing recommendations. So, you know, the nightmare scenario is that you prescribe the opioid and someone dies, they overdose. And if you were not in line with your institutional protocols or recommendations, you really don't have much legal protection there after that. Document your conversation regarding opioid risks and harms. So I have a dot phrase for this, but hey, I told the patient these medications carry the risk of altered mental status, constipation, dependence, use disorder, and death. Putting that in your chart really does let whoever's reading it next know that you had a thoughtful conversation with the patients about these harmful medications. And I'm a big fan of applying a stop date when I prescribe an opioid. So I say, okay, it's January 1st. We're starting you on this medication. I don't want you taking this medication after January 4th. That is your stop date. And writing that explicitly in the chart is also a signal to their primary care provider, to their surgeon, whomever, that this is not intended to be a long-term prescription. Because with the EHR these days, we all know that things can kind of get set on autopilot. And suddenly that short-term prescription is something that's getting renewed every month. Along the same lines there of protecting yourself is avoiding thinking in drug names and starting to think in milli morphine equivalents. The reason for this is not all opioids are created equal, and sometimes patients will come in with a specific request and they'll say, oh, you know what works for me? Those fentanyl patches work great for me. And if you're not used to prescribing fentanyl patches, you might say, oh, it's only 50 micrograms. That seems so reasonable. But 50 microgram fentanyl patch is 120 millimorphine equivalents. And in general, most guidelines state that if the total prescription is more than 100 millimorphine equivalents, then you are putting your patient at risk for developing opioid use disorder. And so a single patch would exceed that guideline. I simply do not prescribe fentanyl patches. I don't think there's a role for them in human medicine. We could have a journal club about that, but there's a lot of opioids out there that are just overly strong in terms of millimorphine equivalents. And then if you look at the list, I actually just use morphine sulfate. I prescribe morphine sulfate tabs when I prescribe an opioid. And the reason is the math is easy, it's cheap, it's generic, it's immediate release. It kind of plays by the rules, and there's no reason to go to these special formulations if a patient doesn't have an intolerance to those. But if you're not used to thinking in millimorphine equivalents, I think it's a great practice to get into. You can use a calculator like MD Calc. You can get an app on your phone. The CDC has an app for this. And once you do it, just for a couple of weeks, honestly, you'll have it all memorized and it'll be second nature. But I think it is important to know what we're prescribing. That sounds very simple, but it's a real thing with these drugs. And then a big asterisk there at the bottom, buprenorphine does not count in the millimorphine equivalent calculation. Why not? Buprenorphine is a partial agonist, and it's actually protective against opioid use disorder. It's protective against overdose. It's protective against cravings, and it doesn't fall into the same calculation as the other millimorphine equivalents because those are full agonists, not partial agonists. And then the final boundary here is to prescribe responsibly. This is kind of summing it all up, but we're using short-acting opioids only. So you have to have a really good reason if you're prescribing an MS Contin extended release or a fentanyl patch, etc. We're using immediate release opioids only. These are the lowest risk for developing dependency. We're using short courses and low pill counts. We're trying to keep those medication cabinets empty. In fact, this graphic here, looking at the medication cabinet all full, just gives me, makes my stomach squirm. So that is not the model there, right? Medication should absolutely be under lock and key. I don't think we counsel our patients on this enough, but we know that firearms should be kept under lock and key. The opioid use disorder deaths exceed firearm deaths year after year after year in this country. And then the goal is not to have this stick around to your next illness, right? You don't want to have your oxycodone in your medicine cabinet until you get a headache 2 years down the road. You want to dispose of those pills, whether that is a drug take-back day or a Deterra bag or charcoal bag that neutralizes the drug. You want to have a plan, not just to prescribe the meds, but to get rid of them as well. And finally, if a patient is at risk for an opioid overdose and you still think it's appropriate to prescribe the meds, for example, let's say someone's maintained on buprenorphine, their cravings are, but they're in a horrendous car crash, they've got a bunch of spinal fractures, they may actually need oxycodone on top of their buprenorphine to treat that acute pain. But that patient is also at risk for overdose for obvious reasons. And so you want to make sure that you pair that prescription with directly distributed or a prescription for naloxone as well, the reversal for opioid overdose. So that can seem like a lot. And to help organize our thoughts, we've actually developed at Superior Health Quality Alliance what we call the shared decision-making tool for opioid pain management. And what this is, I'll show you a picture of it. This is a PDF that you can download today. It is printable on 11 by 17 paper. I have mine printed and laminated. I just went to Kinko's or FedEx, and you can give them the PDF and have as many printed and laminated as you want. And we keep it in our physician workstation. And the idea here is, first of all, to make sure your department is all on the same page in terms of how to prescribe opioids and when to prescribe opioids. So it's one thing to have a policy or protocol. This is developed from the most common policies and protocols that are out there, the state guidelines, the hospital association guidelines. But it's also important that people are actually on the same page. And Rachel later is going to talk about these quality improvement tools and how to make sure that you actually change practice. And so the other thing I like about this tool, though, is it gets the doctors, the PAs, the NPs on the same page. It also gets the patients on the same page. When I pull this tool out, there's sort of the blue zone, that's the no opioid zone. There's the yellow zone, that is the alternatives to opioids plus zone. And there's the orange zone out the bottom. That is the maybe an opioid is acceptable here. And if a patient's got an ankle sprain, I just show them, hey, you're nowhere near this opioid zone. You're in the blue zone here. This is, let's just reframe this conversation from the start. And when patients see things in writing, when they know that the whole department's on the same page, it really decreases maladaptive behavior like doctor shopping, opioid seeking, and just kind of sets the appropriate expectation. Like your pain might be an 11 out of 10 for you. I understand that. But on the terms of absolute pain control, it doesn't meet the threshold for opioid pain control. We need to reset expectations about how we can treat your pain effectively, keep you functional without putting you at risk for opioid use disorder. And this tool is built on this CERTA mnemonic, which is channels, enzymes, receptors, targeted analgesia. And the idea here is the mu receptor is just one of those receptors there. So look at all those different options there are to treat pain. And the name of the game is scheduled medication, scheduled over-the-counter medication, multimodal pain control, pairing pharmaceutical pain control with non-pharmaceutical pain control. There's a lot of ways that we can get more sophisticated in treating pain. And this shared decision-making tool will walk both you and your patient through some of those modalities. So if you look at this, I've actually got it squished. So this is on the 11 by 17 graphic. It's kind of a long horizontal line here. And I've cut and pasted the end of the horizontal line to make it fit on a slide here so we can all read. But tier 1, this is the blue zone. This is the idea of aches and pains and sprains, overuse injuries, kind of musculoskeletal injuries, things like that. And it starts with a pain assessment. And I cannot overstate the importance of a pain assessment. When did this pain start? How long has it been there? What have you tried already? What specific doses have you tried already? What makes the pain better or worse? You really want to start that patient off with an idea of what their goals are and what they've already tried. The second part is these conversation starters is setting expectations. I like to let my patients know that, their pain will not be controlled today. Flat out, we're going to take the edge off your pain. We're going to get you on the road to wellness. But the idea that you're going to walk out of my office pain-free is unrealistic. And that re-injury is worse than injury. I think too often we give patients pills and we say, okay, take these until the pain goes away. And they're going to go right back to their kickboxing tournament or climbing up 20 stairs or delivering 1,000 UPS boxes. You have to be a sick person for a little while. You have to lay down, you have to keep your splint on, you have to elevate that leg, really set expectations that if you re-injure this injury, the pain is going to come back and it's going to be fierce. And then when it comes time to medications, you really want to emphasize scheduled over-the-counter medications. So you get a lot more bang for your buck with something like ibuprofen when it's scheduled. 600 milligrams every 8 hours scheduled for the next 5 days. And people with musculoskeletal injuries, they're often young, active people. They're not used to taking scheduled medications. And this is kind of different, right? They're used to popping 2 ibuprofen when they have a headache. And so you want to emphasize that you really get medication synergy. You get a stacked anti-inflammatory effect with scheduled ibuprofen. It pairs well with Tylenol, and you get more potent pain control. A plus B does not equal C. A plus B equals F. That's kind of the idea behind CERTA and this multimodal pain control. And then, of course, don't forget all these other non-pharmaceutical treatment options. Things like immobilizing the joint, ACE wrapping whatever's swollen, putting a heat pack on, a cold pack. I like to do cold for 24 hours to bring the swelling down and then switch to heat. Keep it elevated. And think about functional goals. Like, what do you need to be doing? Do you need to be picking a baby out of a playpen? Do you need to be working on a factory assembly line? Okay, maybe we can get you back on that assembly line, but you're going to need to wear a back brace to limit your range of motion at the waist to 10 or 15 degrees. Really work with the patient and try to figure out how to treat their pain without using opioid pain control. And then the blue and red box here, we're only going to go into it in depth here on the first one because it appears on every slide. But this is the treatment plan duration. How long are you going to try this pain control method? And when are you going to check back in? I think this is part of the reason that patient satisfaction is actually low when we prescribe opioids, is that so often we're sending the patient out without a follow-up plan. I want to know. I want to know if this is working. I want to know how you're doing. I want to know if you're not reaching your functional goals. And if you're not, I'm here for you. We can try the next steps. Because if you're really setting the expectation with their patients that you're going to try other therapies before opioids, you need to give them a means to do that, right? A means to communicate with you and ramp up therapy if needed. So that brings us to tier 2. Tier 2 includes musculoskeletal pain, but it's also a lot of this episodic pain. We're now talking about chronic abdominal pain. We're talking about headaches. We're talking about chronic regional pain syndromes, episodic flares like gout. Again, a pain assessment. And then with conversation starters, we've included the trigger log. The trigger log is the idea of what actually causes this pain, and is there a way to avoid it? Is it coming up again in the future? How are we going to anticipate the pain that comes and then use non-opioid pain control to play some defense against it? And the reason this trigger is so important is because the triggers are what really causes that rebound effect with opioid pain control. When people are anticipating the pain, for example, let's use a migraine headache, for example. If they know that this migraine comes in waves and the migraine comes every 4 hours and the next one's about to hit, that's when people tend to misuse medication. Maybe they take a double dose, maybe they take it early. And with that dopamine release from opioid pain control, that's quite dangerous. That's what can cause opioid use disorder. And so that's especially important here, is to really learn about the patient's pain pattern when they're anticipating their pain and come up with a plan to treat it before it even hits. Again, scheduled over-the-counter medications, but maybe some prescription medications as well. Obviously it depends on the type of pain, but muscle relaxants like Flexeril, cyclobenzaprine, methylcarbamol for chronic low back pain or acute on chronic low back pain. Something non-pharmaceutical like dry needling or trigger point injections. If a patient has a discrete muscle spasm, a lot of times patients come into our healthcare setting because of spasm pain, that Charlie horse pain. If we can relieve that aspect of it, there's a good chance you'll get that patient skipping out of there today. They might still have the chronic pain, but you've relieved that acute spasm. And then you can ramp it up to things like steroid injections for radiculopathy, localized steroid injections if it's a specific disc. There's a lot of different opportunities here, but it depends on what type of pain it is. But that would kind of be the next level after you've maxed out over-the-counter pain medications. And then when we talk about other treatment options, we're still talking about heat and cold packs, et cetera, but we really include our other professionals here, someone who's going to lay hands on this patient. In my mind, it's anyone, whatever works for you. Some patients respond great to massage. Some patients love their chiropractor. I don't think there's a right or wrong answer here. I usually start with physical therapy only because it's traditionally covered by insurance. But I want someone laying hands on that patient and really taking the time, by the way. A 1-hour physical therapy appointment, that's a lot of time to talk about how to be functional, how to get through the day, how to get out of bed, how to enter the shower or the bathtub, things that you might not have time for in a 15-minute clinical visit. But get that person plugged in with a professional who's going to lay hands on them, really work their skeleton, and help them through that pain. Finally, tier 3, this is when opioid pain control might be an option. This is broken bones, surgery pain, or cancer pain. And again, the big thing here is what we talked about before, safe opioid prescribing. So first, I just make sure that we've actually gone through the motions of trying other stuff first. So just because it is a broken bone pain doesn't mean I'm reaching for an opioid. A great example would be a clavicle fracture, a collarbone fracture. That's really close to the surface. I can put ice on a collarbone fracture directly. The collarbone fractures usually hurt because of muscle spasm. You put that patient in a sling and relieve their muscle spasm, they might not need an opioid at all. And then, mobility expectations. Are you right-handed and you broke your right collarbone? Okay, you've got to know that you're really not using your right arm for the next week. Do you need a work note? What's this going to look like? How are you going to adjust your work activities? But if someone has a bad broken bone and they need opioid pain control, yeah, we're talking about the risks and side effects. We're checking the PDMP. And of course, we're using short-acting opioids, immediate release, low pill counts, and a low total MME. And that is the shared decision-making tool in a nutshell. A great tool to share with your partners, to bring to the bedside, and just walk both you and the patient through standard opioid use prescribing practice in 2024. Now, I want to leave time both for questions and for Dr. Dibble, but I thought we could run through a few real-world case presentations. And I call it then and now because what I'm essentially doing is comparing what I used to do when I first came out of residency to what we're doing now. And you'll notice a stark difference, but this is kind of, I call them the bad old days, right? When we didn't know the full risks of opioids and we were prescribing them a little more willy-nilly versus now, thoughtful multimodal pain control, where we're really involving the patient in the conversation. So let's think about a 47-year-old male. He threw his back out. It's 2004. I am Dilaudid. I am diazepam, 30 of Percocet. That really was my practice. That's what we were doing with patients. A lot of risk there, right? That's a large pill count. That's some potent medication. It's potentially episodic pain. And then we're not really checking medication interactions. In fact, we're prescribing two medications, a benzodiazepine and an opioid, that can contribute to respiratory depression. And, the patients didn't actually leave that happy. We kind of threw a bunch of pills at them and took some of the edge off the pain, but there wasn't much of a plan, to be honest with you. In 2024, that patient comes in, we got a heat pack on them immediately, a lidocaine patch, give them some steroids to try to help that disc slip back into place, potent anti-inflammatory like Toradol, maybe a muscle relaxant to help with spasm pain, and then most importantly, a really tight follow-up plan that includes scheduled over-the-counter medications, physical therapy, and a prescription medication that doesn't have serious risk for use disorder. The patients are much happier, I find now, than they were 20 years ago when we were using an exclusively opioid strategy. A 59-year-old female, I'm having a gout flare. Does this look familiar? It's the same story. In 2004, we're hitting them hard with opioids. In 2024, we're actually thinking about a gout flare. What is it? What specialty medications are available, whether it's allopurinol, whether it's colchicine, whether it's a joint aspiration or a steroid injection? There's a lot more sophisticated ways to treat a painful, red hot, swollen joint than IV Dilaudid and 30 of Percocet. A 79-year-old female who cracked a rib. Now, this is one where opioid pain medication actually is appropriate, right? We're now in that orange zone at the bottom of the shared decision-making tool. But look at what we're doing before. IV Dilaudid in the ER, a pretty high pill count. This is a 79-year-old female. I'm putting this patient at risk for acute on chronic altered mental status or delirium, putting them at risk, at a fall risk, at a constipation risk. I really don't want to be there. And again, we didn't understand the risks of these medications fully back in 2004, but now it's a heat pack. It's IM Toradol. And yes, this patient, people often talk about the Beers criteria with the elderly. They say, well, NSAIDs are contraindicated in the elderly, are they not? And the answer is no, they're not contraindicated. They're proceed with caution, just like everything else. And in my mind, the risk of opioid pain control in the elderly far exceeds the risk of NSAIDs on the kidney. But I do prescribe this patient a short course of immediate release morphine sulfate, maybe a muscle relaxant as well, and really say, hey, these are the risks of this. Make sure they have a loved one who's checking in on them. And if it's not working after a few days, the answer isn't more opioids. It's then we really got to get you into pain clinic for a nerve block. We really have to talk about early mobility and physical therapy, those kind of things. So with that, I'm going to pass it on to Rachel Dibble for quality improvement methodology and opioid prescribing, and then I'll be available at the end for any of your questions.
Great. Thank you so much. My name is Rachel, yet again here for another introduction, and we will be talking about quality improvement going off of Dr. Redwood's talk. Next slide, please. So quality improvement. Why is quality improvement necessary? What is the goal? Improve performance internally and externally. And a systemic formal approach, practice and analysis. So when I break this down, other than what is on the slide, I like to think of it in this way. And I think Dr. Redwood did a wonderful job, and particularly with the case studies, so we can see how evidence-based practice has completely really changed in the last 20, 25 years for prescribing. So in that, quality improvement is important because we have to connect the dots. So now we have all of this knowledge. We have tools, for example, that Dr. Redwood has shown. So with that, what we know now, how do we then implement it into practice? So we have to have a goal. What is the goal for our internal, potentially employees and patients, and then externally as well? It should be focused on the actual practice, what is available, lots of ideation around creating a quality improvement program, and then analysis of the data that you have today to ensure that you're capturing maybe some of the gaps, and then you can prioritize what you are going to address in a quality improvement point of view. Next slide, please. So some highlighted quality improvement models that we have actually from ARC, and I do highly recommend going to these. The three that I have highlighted, I do like these. There are a number of models out there for implementation. One is the Network for Addiction and Treatment model, the NIHX, and that is really designed to, specifically for substance use treatment programs and aims to improve access. So that would be something that you want to look at if this is an access and retention and treatment. The Institute for Healthcare model, it really relies on the PDSA cycle and processes. So when we look at tools, for example, in this talk, that would be the model that I would recommend. And then the Agency for Healthcare Research, the 6 building blocks. And when we think of that, that serves as a quality improvement initiative or roadmap. So it really is the roadmap to help primary care practices implement evidence-based prescribing practices, again, the tools, patient experiences, and then the management of how the program is then executed. And then what we're really looking at is where were we, where are we now, and where do we want to go? So these are the things that have to be identified when you get your structure together. And within your structure, another key takeaway is to make sure you have the right people at the table, your policymakers, all of your stakeholders within your organizations, people from every area of staffing. They will all have different angles related to what they actually see. So the example here would be maybe a custodian. He is going to be able to understand potentially in a hospital or nursing home setting, someone who has a different behavior because he has seen Mrs. Jones every day. So that person needs to be aware also that of whatever process it is to ensure that we do no harm with opioids. We all have a responsibility in this. Dr. Redwood also mentioned as prescribers, because things have changed so much. I can point some fingers at me. That was the knowledge that we had in the past. So now we have new knowledge with new tools. So the idea is to implement this. And how we start is get the committee together that can actually move the needle. And that is from different points of view. That is from a DEI point of view. That is from personal experience point of view. And then those are the staff members that you may think they really would have no part in this. But we all have a part in this in identifying for process improvement to save lives. Next slide, please. So how do we implement? I mentioned selecting the committee. I cannot emphasize how important that is to have different people at the table, because when you design your programs, you have to start with ideation, and that's the brainstorming. And that is no judgment, it's a safe space. So you have to have your committee that really fosters this culture. So you're going to ideate and ideate. Then you can hone it down to your priorities of your goals. You might have 1, you might have 3. I suggest no more than 3. And then you start writing your framework. What does it look like? Again, that committee is your roadmap to what's actually happening out in the field, if you will. That's why it is extremely important. Secondly, you have to decide from the get-go, how are you going to measure this? Because if you can't measure it, you can't see the improvement. How will the data be collected? How will it be analyzed? What exactly are you looking for in moving the needle and report it? Address barriers to change. You may have an initiative you want, say, a tool to implement, but there is a barrier. You have to address the barrier first to be able to even go forward with that initiative. Plan and test. So this is when you ideate and iterate, reiterate, revise. So you plan, you do the process, you test it. Is it working? Is it not working? And you can figure that out by your outcomes and your measurables. So this is the structure of a quality improvement program. Next slide, please. So tips for quality improvement. It is ongoing. I want to really emphasize that this is a process that, again, it goes back to your data and measurables. Are you moving the needle or not? You may have to revise. You may have to go back to brainstorming, reprioritizing, and then coming down with your priorities. So the example here would be, so I'll use 2 that Dr. Redwood's already given us. So we have the shared decision tool, and then the MME, just that simple evidence-based idea of MMEs. If you exceed 100, you could be in a no-go zone, danger zone. We need to stop and really look at this. That sounds like a simple initiative. But in that, you're going to have to think about who touches that tool, who needs that tool, how is it going to change our outcomes? And those two tools that he's given in this presentation, I guarantee you will save lives. And I really push using those, printing them out, posting them, creating your committees, designing your programs, starting with these two things, your MMEs, make sure your people are checking the databases, make sure everyone is aware of what an overdose looks like. What are we going to do when we see it? These are all the things that have to be thought about, prioritized with tangible data, measurables, and outcomes. The other principle that I really like to think about is the lean thinking principle. We talked about some of the 6 building blocks. So when we think about lean, we all know, and within our healthcare settings, we may have limited resources, may have gross amount of resources. It could be anything, but when we have a lean thinking principle, we use what we have without waste. So that could be time, that could be human capital, that could be meetings, that could be however you want to think about that. But the takeaway is no waste. And I like to think about that really in time, because that's the one thing healthcare providers have very limited amounts of, and these exercises need to hold value to be able to implement, to do move the needle, to have a quality improvement activity executed that is successful. Next slide, please. So quality improvement tools to be reviewed or things to be considered, creating a charter within your initiative. I also like advisory boards. I like peer review. I like all sorts of things in this world for getting real people at the table. Desired performance statement. What is your aim? It's one sentence. What is the aim? And you can literally think about this and ideate this for a couple of weeks with your teams. It's a lot more harder than it sounds, to be honest, to come up with one sentence of your aim. Then your action plan, that is your work processes, your workflow, or your work plan. Again, that's deadlines, who's accountable to implement this quality project. And then, of course, your implementation strategy worksheet. That is logging and documenting everything that goes, everything that happens along the way. It's really wonderful to then be able to reflect at the end of it, what worked, what didn't work, come out with best practices, to then for your next project, you have that. You may have to re-ideate some things, but you have some nice framework that you can steal from project to project to build upon. Then again, your sustainment checklist. This is also extremely important tool that is out. There's 1,000 of them out there, or you can create one your own, but make sure it is valid and make sure it is reliable. And so when you go through all of these initiatives or exercises for quality improvement, it would be a shame if it wasn't sustainable. So again, in your design process, what are the checkpoints and how is the data going to show that this program is positive and sustainable? Next slide, please. Tools and resources. There are 6 resources here, and I will say that for particularly with quality improvement, the top 2 I highly recommend taking a look at. They have the toolkits for the models there. You don't have to create anything. So again, I challenge everyone to use this information that Dr. Redwood gave us to start a quality improvement program around opioids and shared decision-making, and then prescribing, evidence-based prescribing best practices. And with that, next slide, please. Are there any questions?
Hi, I actually have more of a comment than a question, but I was looking at next year's formulary for a family member who is on Medicare, and I was surprised to see that lidocaine 5% patches and cyclobenzaprine both require pre-authorization. So I just thought I would bring that up since those are some of the adjuncts that might normally be prescribed in lieu of opioids or along with other non-opioid multimodal meds. But it just seems like that might be another higher threshold for the patient, another hurdle to have to leap over in order to get something, a medication that's appropriate for treating their pain that is not opioid in nature.
Thank you for calling that out. I hadn't heard that yet. I'm not surprised. Sometimes it feels like you're taking 2 steps forwards, 1 step back. And as we transition away from prescribing opioids and towards prescribing other medications, that's going to hit the balance sheets of the pharmaceutical companies, and they are going to adjust course. I do know that lidocaine patches 4% are available over the counter, and they're generic and affordable. So that's an option that I give frequently. But yeah, it's true. You hit roadblocks. The big one that that really makes me groan is when you try to prescribe physical therapy and somebody's insurance doesn't cover PT. And so now you're kind of having someone who wants a non-pharmaceutical approach and you feel pigeonholed into a pharmaceutical approach. And so I've gotten to learn a lot of bedside physical therapy techniques and, try to give somebody a 1 or 2 minute tutorial on an exercise they can do at home if it's not covered by insurance. But yeah, we have to get creative. We have to adapt. And when we hit a roadblock, go for the next alternative.
Yeah, and one other comment I'd like to make is don't forget osteopathic physicians, because there are osteopaths who practice OMT as the main part of their practice. And I myself see an OMT or go to an osteopath once a month for OMT for chronic back pain, and it really does make a difference. And it's probably more likely to be covered by insurance because the procedure is performed by a licensed physician versus a chiropractor. Just a thought.
I love that. You can't see me, but I'm nodding vigorously. A great
Okay.
call out. Absolutely.
Thank you for that. Wow, that's a good workaround. Thank you.
You're welcome.
I love to learn it. Thank you.
Rachel, I'll chime in. I always take notes when you're presenting. I love your quality improvement techniques. And I know with the Midwest Alternative to Opioids project, a big denominator for us was total millimorphine equivalents prescribed by the department. So it's pretty easy to build a report in your EHR for how many millimorphine equivalents were prescribed or used when someone was in your department. I'm in the emergency department, of course. And you could just run the report. So at the end of the month, if you're prescribing, 10,000 MMEs at the end of the month, that's your number. You just try to work it down. And we prescribe so many opioids in the US, there's a pretty good chance there's an opportunity to nudge that number down. And what we found was that when we're all rowing in the same direction and the department's all trying to work on their opioid prescribing habits, you did have some outliers. You had a couple of physicians who were really contributing to a third or a half of the opioids being prescribed. And when you can run the data in that way and kind of show them, hey, look, your prescription habits are really outliers here. This is what everybody else is doing. This is our departmental protocol. I think that can actually be a powerful tool. We're pack animals, right? We want to be within the herd. We don't want to be outliers. And that was really a powerful way to look at the data for my department.
And I will say again, it's could be state to state, depends, but I will say insofar as recertification, I think it's super interesting with what they have to say. In insofar as like PM, they are tagging prescribers themselves. When I think about a process, sorry, I was thinking about the process. To then we have to take, I'm a nurse practitioner by trade. I think it's 10 more hours if they have tagged me as a high prescriber. So I think that is a great quality improvement tactic or strategy that the DEA took. It's on a state level, it's through my board, but if I was tagged by the feds, then I have to take more hours in my updating my license.
Exactly. Help me help you, right?
Exactly.
Mhm.
Exactly. So that's again, so what they had to do was look at the numbers, and they got down on the individual level, which is also terrifying as a as a prescriber, but that's what they had to do because our deaths are so high. So they went about it in a quality improvement way of they've done the education, they've gone through all of these things for years. Now they're tagging us, like specifically. You'll get an email that says you're a high prescriber. So that was their way of of quality improvement. Again, data driven, like Dr. Redwood said.
Yeah, I want to share too, in the state of Minnesota, this started back in 2019 or 2020, where the state collects, through claims and such, they're collecting data on the MMEs being prescribed by providers. And they set up thresholds depending on the population, your specialty, that kind of thing. And if you fall too far above the threshold, you have to submit a corrective action plan on how you're going to bring that down to that threshold, below that threshold, and submit it to them. So that, the first time providers heard that, of course, they were very concerned, nervous, so we had a meeting with our, members and the MDH to talk about it and come up with something that's reasonable. But that was the state of Minnesota's plan to get the prescribing down.
One of the innovations I like is that we're the no-go zone. The idea that we're now saying these are conditions where it's really not appropriate to prescribe opioids. I think we as a medical profession were a little bit nervous to say that for a while. The evidence was still evolving. We didn't want to make patients feel like their pain wasn't going to be treated, and maybe the alternatives weren't that well developed yet. And now with this robust alternative to opioid curriculum and eyes wide open view of the harms of opioids, we've really decided we're just not going to treat XYZ with opioids anymore. And I think that's been a pretty powerful practice change as well.
Well, we are coming up on the hour pretty soon here. I want to thank all of you for attending, whether it was only this one or several others in the webinar series. We are very passionate about opioids. Superior Health is. So we enjoy working with our members to get these rates down. So thank you all. Goodbye.